Atopic dermatitis is one of the common dermatological conditions that we usually see in our clinic, and today we shall take a look at how it comes about, the best way to manage it, and actually how do you follow up patients that you've made for a diagnosis of atopic dermatitis. I'm Dr. Abraham, and I'll be taking you through this session. So starting with the pictures that we can see here, the pictures we see here show you that atopic dermatitis can complicate into other things if not well managed. As you can see in the first picture here, you can have a condition we call eczema hepaticum. And in that case, someone gets disseminated viral infection from HSV because they are atopic. And then in this next picture, we see these giant molluscums that can be disseminated all over the body, especially for patients who are atopic. And then you can also get these extensive erosions and ulcers if you don't control the atopy, and this can end up super infected and complicated. So looking at atopic dermatitis, it's one of the most common conditions that we usually see that involves inflammation of the skin, and its prevalence has been rising in the past decades, and it will continue to rise because of the change and socioeconomic status. And this is very key because we have to note that with time, so many cases of atopy are going to arise. And you'll find that the key features that we usually look for, it will be the pruritus, which is itching, and it occurs in 100% of patients with atopy. And then it has a chronic relapsing nature. A patient will have an episode this month, then later on they get another episode, and they'll have that history. And onset can be either depending on sometimes the onset is early, and other times the onset is a little bit late, and other times the onset can be senile. So atopic dermatitis is also associated with other conditions where we call them the atopic match. And early in life, the infants or the children will have other coexisting conditions that also show sensitivity. That can include food allergies, that can include asthma, allergic rhinoconjunctivitis, and the rest. And we're going to see how this comes about. And in management, we usually encourage that it goes beyond treatment of the current flare, but to make sure that you strengthen the skin barrier and then you do maintenance and minimize relapses. So the aim is usually to prevent progression to other atopic conditions as well as prevent complications. So when I look at the history of how this condition came into clinical description as an entity, we look at it like in the 1892, we see a scientist called Besner who associated actually atopic dermatitis, what we're seeing on skin, with allergic rhinitis, and then later on, the term atopy was picked from a Greek word, which atopos, which simply means unusual or something put out of place. And in that time, that's when they introduced this term, atopic eczema, in the 1920s. Then, in 1933, we see Hill and Salzburg coming in to propose the term atopic dermatitis to coin the name actually to which we currently use up to date. Then later on in the 1980s, Hanfin and Rajka came in to describe actually the key features that you see in atopic dermatitis and give us a diagnostic criteria, which is still even applicable up to date, the Hanfin and Rajka criteria for diagnosis of atopic dermatitis. Then in the 1994, we see that we had the UK's diagnostic criteria that was proposed by William and the friends, and currently it's not so much used. In our setting, we usually use the Hanfin and Rajka, but it is also existent. And in 2003, we see that they also revised the diagnostic criteria by the American Academy of Dermatology, and then they proposed a more simplified criteria for diagnosis of atopic dermatitis. Then when you look at atopy, simply atopy has been linked to allergen-specific IgE antibodies. And in this case, most of the patients, when you do a skin prick, it can be positive. And as well as when you do the RAS test, that can help you identify the different allergens that these patients are reacting to. So in literature, you'll find that atopic dermatitis has been divided into two forms, where you have the IgE-associated atopic dermatitis. In this case, you'll have a patient having presence of a specific IgE antibodies. And in this case, usually the onset is a little bit early in life. And then you have also the non-IgE associated atopic dermatitis. In this case, there's no IgE sensitization, and usually this one comes in a little bit late, until around the adolescent time. Then you can also have an overlap of these two. Someone starts with both having both the IgE and non-IgE sensitization. So as we're talking about the atopic march, in this diagram here, this is what we actually meant. So you find that early onset, it will be usually what you call atopic dermatitis will be the first one, coming in at around the second or third month of life, around here. Then later on, the children will develop food allergies, either peanut allergy, milk allergies, and the rest. So, and then later on, then they develop asthma around, make a diagnosis of asthma at around 2 years of life. If a child has that wheezing 2 years, then you make a diagnosis of asthma. Then later on in adolescence, or later on around 7 years, then you start getting manifestation of allergic rhinitis and allergic conjunctivitis. So that one a little bit comes in a little bit later. So that is the atopic match. So someone starts with atopic dermatitis, then food allergies, then asthma, then they end up with allergic rhinitis. So some people can have the entire group, or they can just have a few of these conditions. So when you look at how common is atopic dermatitis is a little bit more prevalent, especially if you look at countries which have a little bit of higher income status, who are maybe in first class, second class. As you go down the ladder, the prevalence also goes down. And we find that the prevalence in those countries can go as high as 30%, but on average, around 20% in children. But for adults, the prevalence can be around 2 to 10%. And the trends have been increasing in the last 2 to 3 decades, and you find that maybe it was around 10, now 20%, and there's a projection that with increase in socioeconomic status, the cases of atopic dermatitis are going to increase. And you find that if you look at the geographical location, lower prevalences are seen in rural areas and low-income settings. And as you go to middle class and the rest, the prevalence is also increased. So that's where people thought about the dirty, the dirty clean theory. In that way, they're thinking that if you're in a low-income setting, you're exposed to a lot of infections, a lot of sensitization, a lot of dirt and antigens from the environment. Because of your exposure, your body undergoes hardening. So at the end of it all, you are less sensitive, actually. You are less sensitive to environmental triggers, as opposed to an individual who is staying in better settings where there's more income, so they are in clean environments, less contamination, less, so they are actually less sensitive. So when they get an environmental trigger, actually they're very, very sensitive. Then we can also classify atopic dermatitis based on the age of onset. We can say, we can call it early onset. For example, if it begins within the first years of life, commonly that is in the infancy period, and you find that up to 45% of these cases who have early onset, it occurs within the first 6 months of life, and usually 85% before the age of 5. And you find that the other classification, the late onset, occurs after puberty, and in this case, there are no much studies to try and see and categorize them, but we call that late onset. And mostly these are non-IgE associated cases. We said that in this case, they don't have IgE sensitization. Then the last onset, by classification, we call it the senile onset. This is a little bit rare, and it starts over 60 years of age. So when you look at the pathogenesis of atopic dermatitis, this is a condition that has an interplay between the genetic predisposition, the environmental factor, then somebody's immune dysregulation, alteration in the microbiome of the individual, as well as the alteration in the skin function or the barrier function of the skin. So as you're describing the pathogenesis, you should remember to mention all these interconnected pathways. So you have your genetics, you have the environment, you have the individual's immune system, the changes in the skin microbiota, and then the dermal barrier dysregulation or dysfunction. So those are the factors that we consider. So every time you try to describe how it comes about, please remember all that. And we're going to see how each of these comes into play to end up with a child having atopic dermatitis. So starting with the genetic contribution. So in this case, we see that the genetic contribution is very high, up to 90%, especially in the early onset atopic dermatitis. So in that case, even when they did studies among this monozygous twins, you find that confidence was up 77%, and the dizygotic twin, it was up to 15%. You know, monozygous twins, that means that they almost share everything. So even the risk of them getting atopic dermatitis was also very, very high. When you look at the gene interactions, mostly the gene that is affected in atopic dermatitis, we call it the fibrin gene, and this gives rise to the fibrin protein that has key function in protecting the skin, or in the skin barrier function. Then other genes have been shown to be involved in the regulation of the T helper 2 immune responses, as you're going to see. And you find that when someone has a mutation in the fibrin gene, it simply means that their skin barrier function is impaired, because the fibrin gene usually it gives rise to what we call the fibrin protein, and fibrin protein is usually further broken down to produce specific amino acids, especially the histidine and the natural moisturizing factor of the skin that allows your skin to be well hydrated and moisturized, and it protects you against irritants. If you don't have the fibrin protein functioning, it means that you don't have the natural moisturizing factor, you don't have the histidine that is usually absorbs water into the skin to make it well hydrated. So that means that your skin will end up being very, very dry and are prone to irritation. So that's how the fibrin gene comes into play in atopic dermatitis. So this one will say that most of the times, if it has a genetic implication, the onset is a little bit early. And we've seen this gene also being implicated in other disorders of conification. For example, we see fibrin gene being deficient when it comes to keratosis pilaris. We also see it dysfunctional in ichthyosis, the ichthyosis vulgaris. It is also the defective gene in that type of ichthyosis. That's why you find that most of the patients with atopic dermatitis is also most of the patients with ichthyosis vulgaris, they also have some aspects of atopy. When you come to what is the net effect of you not having this gene, is that if you don't have the histidine in the skin and the normal moisturizing factor, you end up having a raised pH of the skin. So with a raise in the pH of the skin, that reduces the natural hydration. The skin will be dry, easily irritated, and it will have high risk of infection because you have altered the pH. So you favor colonization of bacteria that can thrive in a more alkaline pH, and that is the Staph aureus. So research now currently is focusing on to see how to improve the skin barrier function with other things that can mimic the natural moisturizing factor of the skin, and we find ourselves using things like emulsifying ointment to try and replace what is deficient in someone's skin. So when we look at the epidermal barrier dysfunction and the microbiome, we've hinted on this already. So we usually have increased transepidermal water loss because you're not having a well-made skin barrier. So you lose a lot of water through the skin. And this one simply indicates that your skin dries out very, very fast. So, and that usually correlates with the severity of the condition. So with the more the increased transepidermal water loss, the higher the risk of severe forms of atopic dermatitis. And we've seen the role of this gene, the fibrin gene, and other protein, and other proteins that have been implicated as well. We include involucrin, cyclin, and then also the claudin one. And you find that when you talk about the altered skin microbiome, you see that after you altering the pH of the skin, making it more alkaline, you'll end up having more or favoring more colonization of Staphylococcus aureus bacteria. And we find that in most of the patients that have a flare, usually it is predisposed with a high colonization, or like a surge of colonization of Staph aureus. And we find that most of them, not 90% of patients with atopy, the colonization of Staph aureus is the major bacteria on the skin, as opposed to the ones that are not atopic, where Staph aureus only contributes to only 5% of the skin microbiome. And because of the colonization of Staph aureus, no Staph aureus is a pathogenic bacteria, so it will produce for you toxins that will drive the T helper 2 immune response processes. So that's how we end up with actually triggering the atopic dermatitis. So we find that, as I had mentioned earlier, that in flares, you see a lot of Staph aureus proportions increasing, especially when someone has a flare. You find that their numbers for Staph aureus are a little bit through the roof. So when you go to the immune dysregulation in atopic dermatitis, we find ourselves discussing these hard things that people take hard, but actually when you go slow on them, they'll actually make sense. So in acute atopic dermatitis, we know the immune response is basically driven by the T helper 2 cells. And then we know that T helper 2 cells are associated with production of cytokines, especially interleukin 4, 5, 13, and immunoglobulin E. So meaning that when you have immunoglobulin E, which is an allergy immunoglobulin, so this is a type of atopy that can be stimulated by things from the environment, including clothes, soap, perfume, things that come from the environment, acting as trigger, stimulating production of IgE that drives also the reaction, as well as activation of the mast cells, causing degranulation and eventually causing you or causing you an inflammatory process. And then when it comes to chronic atopic dermatitis, there's a shift between from T helper 2 to T helper 1, T helper 22, and sometimes even T helper 17 cytokines. So in chronic phase, atopy there's a shift from T2 to T1 based immune response. So when you look at the different cytokines and what they do, starting with interleukin 1 and 13, usually these ones help us to drive the T2 immune response, and have been targeted by drugs that try to minimize their function, like dupilumab. We know that is a new biologic that we're using in treatment of atopy. Very, very effective, but it's a little bit costly and not affordable in our setting. But that's where the target is. Then we also have the TSLP. This is this lymphopoietin from the keratinocytes, and this is, we call it a master switch of allergic inflammation, and it also triggers the T helper 2 via the dendritic cells to give us to the T helper 2 driven immune response. Then another one is interleukin 13 and 33. These have been linked to the pruritus in atopic dermatitis. That's why when you're managing pruritus in atopic dermatitis, your antihistamine play no role, because you don't have histamine as the mediator of itch in atopic dermatitis, but we have interleukin 31 and 33 that also contribute to the itch. So that's why when you're treating itch in atopic dermatitis, actually your antihistamines have no role. Maybe if you're using them as sedatives, maybe for the children who are small, and then maybe in the night when they have a calm sleep, you use now the antihistamines basically as sedatives, but not as antipyretic medications. Then emerging treatments include antagonists for interleukin 31, and that is the nemolizumab. And there's a thinking that maybe if it becomes approved, it may be also used to try and reduce the pruritus that comes with atopic dermatitis. Then we have also a potential for bacterial therapy, where we want to reduce the imbalance and the supercolonization of Staph aureus, which drives the atopy in most of the cases, especially in the flares. So if you look at this flow chart tries to show you the interaction between the factors we talked about. Remember, in atopy, we say that one, someone has a genetic predisposition. Two, we have environmental factors coming into play. Then three, we have impaired barrier function. Then we have immune dysregulation of the host, all coming together to work together to give you the net effect of atopic dermatitis. So in this flow chart, you see environmental factors coming in here, where you have them maybe like infections, like what, are coming in, or different allergens from the environment. Because of the impaired barrier function, they can easily penetrate into skin. And when they reach there, they will trigger IgE stimulation and inflammatory offset in the skin, giving rise to the activation of T helper 2 immune response. Then that drives the immune response that we see in atrophy. So this can be bacteria, we can have allergens, or even irritants like soaps and the rest. Then we have the impaired stratum corneum. We've seen it having a genetic implication where someone has decreased fibrin protein that gives rise to the reduced hydration of the skin, increased permeability of the skin, so that irritants can easily go through. But then at the same time, usually have increased proteases, especially the paracrine proteases 5 and 7. These ones usually do help. What they do is that they cut the proteins that are supposed to cause adherence or to keep the corneocytes together. So at the end of it all, even the corneocytes are easily separated, causing like channels which can allow allergens and irritants to go through skin easily. Then we also have abnormal lipids. In this case, we have increased lamellar body and then lipid processing. And that in that case, that means that the functionality of the skin barrier is impaired. So now this one works together with the immune dysregulation, where you have both the adaptive and the innate system coming into play. And in that system, we have cells like the lymphoid cells that usually reside in the skin, and these respond to antigens. And then we also have the active response from the T helper 2 cells that produce cytokines, including interleukin 4, 5, 31, 13, and then the IgE. Then in chronic phases, we see it switching to T helper 1 immune response. So all this, at the end of it all, they'll give you the pruritus, they'll give you the lesions that you see on the skin, and it will give you the picture of atrophy that you see on the skin. So when you go through the clinical picture, that's how do we see atopic dermatitis and how is the disease caused. We also divide it into age-dependent stages. Starting with, we have a group that we call the infantile onset. So that is the one that occurs below the age of 2 years. And in this case, it commonly begins at around 2 months after birth. And oftentimes it will start on the cheek, but sparing the central face. So the infant will have a lot of edematous papules, vesicles, oozing, crusting. It can also affect the scalp, the neck, the trunk, extremities, but most of the time it will affect surfaces that are in contact with the environment. So if the child has started crawling, even the hands can get affected, the elbows, the knees, the cheeks here. So it will affect what we call the convex surfaces of the body, even the skull. Then when we go to the second classification, we call it childhood atopic dermatitis. In this case, anywhere between 2 years and 12 years, we call that childhood atopic dermatitis. So in this case, this is a little bit more or less exudative as compared to the infantile type. And this one shows more like lichenification, and it loves the flexural areas, the antecubital fossa, the popliteal fossa, and that is the typical morphology of atopy in this particular age group. And then other sites it also loves the wrists, the hands, the ankles, the feet, the neck, and most of the times, these children will also have a very, very dry skin, what we call xerosis. Then the next type, we call it adolescent onset, or sometimes some books call it adult onset. Usually this one starts if the child is above 12 years, but below 60. So that is adolescence stroke adulthood. So still in this particular age group, it will be a little bit more chronic. That will be a little bit more chronic with lichenified lesions. They can also usually get the chronic hand dermatitis, facial dermatitis with severe eyelid involvement. We are going to see the local variants, and we shall see that more. And most of the times, it is a little bit more severe and long-standing compared to the one of children. Then the last category, we call it the senile. And in senile, we see that this is an onset that occurs after 60 years of age, and it is usually marked with xerosis with typical facial lesions. So most of the times, patients will start with a lot of like dry skin, itching, and then later on they develop these itchy rashes in the flexural, the neck, and they'll come with a generalized xerosis. So when you look at the general features, if you're to categorize acne and how the lesions will look like. So if it is an acute lesions, it will be edematous, meaning that swollen with water. Edematous will look red and there will be like plaques. Then that will be now the acute lesions. Then we have what we call the subacute lesions. In this case, the edema will go down, but there will be eczema, scaling, and then crusting. So that's the subacute lesions. Then in chronic lesions, you'll see the thickening, the lichenification. They can even get prurigo nodularis-like lesions that it can make you think that maybe this is prurigo nodularis. Then we can also get exfoliative erythroderma. In this case, someone has involvement of almost the entire skin, more than 90% of the body surface area. And in that case, you'll find them getting exfoliation generalized almost everywhere on the skin. Then after that, we also have what we call the post-inflammatory changes, which can either be hyperpigmentation or hypopigmentation. And in some cases, some patients can actually end up getting depigmentation, where it may look like vitiligo, yet this is a sequelae of atopic dermatitis. Then we have what we call regional variants. So sometimes in some individuals, you'll find that they don't get the overt or the typical atopic dermatitis covering everywhere. So they end up getting with what we call regional variants, like atopic lesions, but located on only a particular site of the skin. So the first one is what we call the arthritis or lip eczema. So in this case, some people call it lip lickers eczema. So someone will get like dryness around the lips with chapping, especially of the median lips, and oftentimes it is worse in winter. Usually winter is very dry, and they may also get peeling, fissuring, even angiachitis. And most of the times, they also we can call it lip lickers eczema for people who actually lick the lips, and they end up with a well-demarcated plaque around the oral opening. Then you can also have it affecting only the ear. That one, in that case, we shall call it the ear eczema. So someone will have a eczema, scaling, fissuring under the ear rope, especially behind the ears, the auricular area, and may be complicated with superimposed bacterial infection, and then they get oozing and pus discharge from the ears. Then you also have what we call the eyelid eczema. In this case, someone has lichenification of the periorbital skin, this skin here. And oftentimes it can also be confused with the infection with the candida infection that involves the eyelid. So it can actually, in some patients, can be the only manifestation of atopy. Then we also have what we call the hand-neck dermatitis. This usually occurs after puberty, affecting the face, the scalp, the neck, and oftentimes it has been associated with myasthenia infestation, and these patients respond to treatment with antifungals. Then we also have the acro variants of eczema or atopic dermatitis. The first one being the juvenile plantar dermatosis. You're going to see a picture. In that case, someone will have a glazed erythema and scaling, oftentimes affecting the end part of the foot. You can also get atopic hand eczema, which usually affects the volar wrists and also the dorsum of the hand. And oftentimes, someone will have deep-seated vesicles and pustules, or even papules that can also be called the dyseidrotic eczema. So in some patients, they can end up with what we call prurigo nodularis-like lesions, which are usually firm dome-shaped papules on the extensor surface, oftentimes with a scale or even a crust. So this can resemble the prurigo nodularis that usually seen in the pruritic disorders. Then you can also get what we call the nummular or the discoid eczema. So this is a coin-shaped oozing plaque that oftentimes is about 1 to 2 centimeters in diameter, usually found on the extremities. So you can have atopic dermatitis presenting with nummular morphology, and that is actually different from nummular eczema. So those two things are different. You know, dermatology with the terminology, things can look similar, but when they're actually meaning different things. So we can also get what we call the frictional lichenoid eruptions, oftentimes on the feet, on the elbows, the knees, or the bosoms of the hand. And they will present with the flat-topped papules, which are usually very, very small. So this can also look like what we see in keratosis pilaris. But in that case, we call that if it is patient is atopic, we call it frictional lichenoid eruption. We can also get what we call the chronic nipple eczema. It can occur in children, even adults with atopy, where they get a well-demarcated oozing plaque around the nipples, and you're going to see a picture. So we have what we call the associated features in atopic dermatitis, and if you don't see this, you don't make a conclusion that this is atopy. So a pruritus is one of the features that is usually very, very specific in atopy. It has to be there for you to say the patient has atopic dermatitis. So if you see a rash without pruritus, it is not atopy, 100%. And in this case, pruritus is very, very intense. Worse in the evening, can be exacerbated by sweating or even wool clothing, rubbing and scratching can lead to flares and skin thickening. And then they can end up with also excoriations, which can either be linear or punctate. Common time, it is when you see excoriation, this is indicative of someone who is scratching. Then you have the atopic stigmata. These are the things that you see after someone has had atopy. You're going to see a table for it. Then you have what we call pityriasis alba, which is commonly seen in children or even adolescents with atopy, presenting with hypopigmented macules, usually around the face, can be around the face, on the sides of the eyes here. So most times it also visible, especially if your skin type, this skin type is a 4, a 5, or a 6. It will be very clear for us to see the pityriasis alba. So it may be actually subtle or maybe the only presentation, which indicates that someone has a sensitive skin. So when you go through the differential diagnosis, if it is pityriasis alba that you're thinking about, you have to make sure that it is not post-inflammatory hyperpigmentation, it is not pityriasis vascular, or even vitiligo, alley shape if it's already demarcated, and then can also be the hyperpigmented mycosis fungoides if someone is older. And then in case of, so you can also get actually lesions that can mimic photo or what we call um, polymorphic light eruption, especially on the face. It can give you lesions that can look like pityriasis alba. So if it is infantile atopic dermatitis, usually it has what we call the typical morphology or the typical distribution. And in the typical distribution, we said for these infants, they will the rash will favor areas that are more convex, the convex surfaces of the body. So that will include the forehead, the cheeks. It can be also in the neck, the scalp, the occiput here, the elbows, the knees. So that will be the common area where these rashes will be for an infant. So as you can see here in this illustration, this is how it will look like, there and there. So these are the most common sites, but oftentimes if they get autosensitization, then they can get a generalized rash with follicular accentuation and the rest, and the erythematous papules and covering maybe the rest of the body. But oftentimes it spares the diaper area. So as you can see in this picture, so this is now a severe form in a black patient, where you see this lichenification, scaling, crusting with erosions. With erosions, as you can see, if I magnify for you, you see these erosions here, which is punctate, and then in this patient here, you can see this area being affected, but majorly the central face is spared. As you can see here, central face is spared, and then the rash is covering the cheeks, and this is very typical for the infantile atopic dermatitis. So when you go to the childhood and adolescent atopic dermatitis, so in that case, you'll see patients that are having eyelid eczema. This one we talked about it. You're going to see a picture. You can see dryness. You can see eczema, scaling. If someone has lip licking, they get lip lickers eczema. Then dyshidrotic eczema, which affects the hands with the deep-seated vesicles and papules. Then you can also get the juvenile plantar dermatosis, which affects the foot. And we can also get it affecting head and neck, the ears, the nipple, the frictional eczema, and then the prurigo nodularis-like lesions, and then atopic hand and eczema. Then you can also get numeral lesions, as we talked about previously. We're just going to see now the pictures. So in this case, this is the flexural area. So the typical morphology in childhood and adolescent, as well as the adulthood or atopic dermatitis, it will involve the flexural areas. As you can see here, you see plaques there on the antitubular fossa, then usually around the wrist. This is also a flexural area at the ankle joint. Then this is lip recurrence eczema. This is now atopy affecting the lips, both lips. And then this is nipple eczema, where you see lichen-fied plaque affecting the nipple and the areola area. Now this one is atopy, giving you pneumolar morphology. And then this is eyelid eczema, which can be confused by blepharitis, which is from Candida. And then this is what we call the ear eczema, as you can see here, whereby the ear is having this scaling, excoriation, and the rest. And then this is also now another picture showing the pneumolar eczema. So that's how the pictures will look like. Every time you see this, at least have an idea that maybe you are dealing with a patient who has sensitive skin. So going further, looking at the diagnostic criteria, as we've said earlier, so depending on the practice that you're having, you can have different criteria that you can base on to diagnose atopic dermatitis. But the one that has stood test of time is the Hanfin and Rajka diagnostic criteria, but we've seen it being up, people suggesting more newer criteria, but we have somehow gotten stuck because a little bit it is extensive and it will give you most of the features that we usually see in atopy. So we have what you call the essential features of atopy, and these are the features that are supposed to be there. The first one is pruritus. So someone will have rubbing, scratching that can usually initiate or even exacerbate flares. Then they have the typical eczematous morphology, and then the specific age onset. So you find that in atopy, we will look at, after knowing that it's pruritus, we will look for the typical morphology depending on the age of the patient. If the patient is an infant, we expect the rash to be on the concave surfaces of the body, including the cheeks, the forehead, the scalp, the knees, the elbows. So that's where we expect the rash to be. So if you are now dealing with a child or an adolescent or a senile patient, we expect the rash to be in the flexural areas, that in the antitubular fossa, popliteal fossa, the neck, then maybe with cirrhosis. So the typical morphology is one of the diagnostic criteria. Then it should have a cause that is chronic and relapsing. So someone should have a risk of having multiple onsets or multiple episodes that come and go, made worse by particular things, and then that's also part of the diagnostic criteria. Then other important features include things like early onset, if it comes in the childhood or infancy, if someone has a personal history of atrophy or in other features which lie within the atopic mass, that is asthma, allergic rhinitis, the food allergies, then they should have xerosis, that is means dry skin. Then other associated features follicular prominence, we call it maybe for accentuation, follicular accentuation, other things like ocular findings, like lupine conjunctivitis, the Dan Morgan folds, the other features that are a little bit salient, but they also or they contribute to the diagnosis. So depending on the criteria that you're using, if you're following Hodgkin and Rajka, it will have your four major features plus 23 minors. So if you're following other criteria, you'll have actually fewer. But Hodgkin and Rajka is a little bit extensive and covers almost every feature that you see in atopy. So triggers that have been shown to worsen pruritus or atopic dermatitis include things like climate, where you have extremes of temperatures like the summer and the winter, low humidity coming into play. They have other things like irritants like wool, perspirants, detergents, solvents, infections like staph aureus, other environment allergens like dust mites, pollen, contact allergens, other foodstuffs, and things like egg, milk, peanut, and the rest. And then you'll have other things like increased IgE that usually detect, and rust test will be a little bit positive. So when you look at atopy, atopy can also complicate as any other condition. So complications can range from superimposed bacterial infection, and in this case, we usually have a shift from T helper 2 to T helper 1. And you know that in atopy, T helper 2 usually not that defensive against infection. So you usually have superimposed infections in atopy, most commonly by staph aureus and then also staph hygiens that can also give you things like carbuncles, things like folliculitis, pharyngitis, and the rest. Then you can also get atopy presenting or complicating eczema hepaticum, which is like exaggerated HSV infections, instead of having maybe vesicles localized in one dermatome. If the patient is atopic, they can actually end up having vesicles all over the body or particular region, as you saw in the previous picture in the introduction. Then we can also have molluscum contagiosum becoming more well disseminated because the body cannot fight it off. And then other things like atopic keratoconjunctivitis can also come in as complications of atopic dermatitis. So as you can see here, this is eczema hepaticum, and these are erosions. Can get super infected. This is molluscum. This is now someone getting phlebitis, so inflammation around the blebitis or inflammation around the eyelids as a result of atrophy. So other things that have been associated, you look at xerosis, you look at Escherichia vulgaris. I mentioned that they share a common gene, the flagbin gene, with atrophy, and as well as keratosis pilaris also shares a common name. Other things like the Dunn-Morgan lines, those are the accentuated lines along the eyelids. And then you can also have a central facial sparing. Then you have the atogy sign, which is usually absence or thinning of the eyebrows, especially in patients with atrophy. And then we can also have what called the white dermographism. In this case, you know that when you stroke their skin, there should be erythema. But for patients who are atopic, their skin is very dry. So when you stroke, you just get a white line. That's what we call white dermographism. Then if you have to do pathology and you take off samples for atopic dermatitis, so depending on the lesions, atopic dermatitis is one of the spongiotic dermatoses. So in this case, you will get a marked spongiosis if it's an acute lesions, because acute lesions is either edematous or erythematous and oozing actually. So you get out of spongiosis, including both the dermal and the epidermis spongiosis. Then you will get eosinophilic infiltration, especially if it is IgE sensitive atopic dermatitis. Then in the subacute lesions, you will get now reduced spongiosis, but then you'll get infiltrations of different types of cells. So an infection, you see neutrophils, lymphocytes, and the rest. But you can get now acanthosis, parakeratosis, as well as hyperkeratosis because of the lichenification that now comes in. So in chronic lesions, which are lichenified, you get now epidermal thickening, you get irregular also, sometimes even psoriasiform pattern of elongation of the red ridges. Then you can also have thickening of the granular layer, like lichen simplex chronicus, and also if it is chronic, you get reduced spongiosis. So as you can see here, let me try to show you in this slide that you see here. So this is an acute type of atrophy, and then you see this now. This one, there's an ulcer here. You see there's no continuation of the epidermis. So this is an ulcer with this is blood, this is serous fluid, this is blood. And then you have the spaces between the epidermis, that whitish that you see, that is the spongiosis, as well as with a few lymphocytic infiltrate, especially around the blood vessels. Then if it is subacute, then you see this a little bit of now thickening. Acanthosis has started to set in with the minimal spongiosis here, and then you see now here parakeratosis coming in. You have a lot of overturning of cells. So that's how histology will look like. So when you go to the treatment, now in atopic dermatitis, the treatment is very key because your target is one, to try and solve the problems that the patient has. either their genetic deficiency, their changes in the microbiota, their environmental triggers, such that they don't get more flares. So the treatment goals include things like you have to control the subclinical inflammation, prevent flares, then prevent atopic comorbidities, and then also do patient education to make sure that they use gentle skincare products, they use clothing that suits their skin, and at the same time, they have to maintain a well moisturized skin. So in this case, you'll find that one, you have to help the patient identify the different triggers that are in their environment. So if it is the clothing, maybe you tell them they're supposed to use pure cotton clothing where they have to remove even the labels that are usually located at the back of the cloth. Then they have to use gentle soaps that are made specifically for sensitive skin. Those are synthetic soaps that just actually form, but they don't have the irritants. Then they have to stay away from fragrance-based skincare products, and then maybe use things that are fragrance-free, preservative-free, that are a little bit gentle and calming to the skin. So when you're doing patient education, you have to make sure that this patient learns what is their condition so that they can actually adhere to the instructions that you are giving them. Because if you don't, you find that they will do the thing for 1 week or two. After improvement, they will stop, then they'll get another flare, then come back and say maybe actually you're not working. Yet in actual sense, it is them that have gone back to the triggering environment. So you also have to make sure that you help this patient go through psychological aspects that come with atopy, the stress, the anxiety, the depression. So you have to tell them that they're not the only ones having the condition. If possible, you can even actually put them in support groups where you get people having a shared diagnosis, then you get them to meet and then they share experience of how the condition has taken them throughout life. Then the other thing that I tell them is that bathing is supposed to be done maybe with some slightly warm water with a fragrance-free cleansers. And in this case, there's something we call soak and smear. After soaking, after bathing, they immediately apply a moisturizer. And you have to tell them that the bathing maybe should be once a day and they should not spend a lot of time in water because you know that water actually dries your skin. After bathing, the skin dries out and then you lose the little natural moisturizing factor. So you end up with a very dry skin. And then the moisturizing is very essential to prevent the dryness, the pruritus, and the inflammation, and then also penetration of the antigens of the environment into the skin. So they should moisturize with heavy moisturizers like ointments, peprolactam based, and if possible, you can even do this under occlusion. Then you can now go to the medication that we usually give. The first line treatment in case someone has a flare, acute lesions, acute rash, we usually do the topical corticosteroids. Then you can do the soak and smear technique. And then the topical calcineurin inhibitors have been recommended, but usually the mainstream in treatment of atopy is corticosteroids. So this one is just maybe in case you have no option. Then we can also use other things like the crisaborol 2% ointment. This is a phosphodiesterase inhibitor. And in this case, that's been approved if someone has mild to moderate atopy in terms of treatment. The patient uses than there is more than actually 2 years. That's when you can use it. So it will inhibit that enzyme phosphodiesterase coenzyme, and that will reduce the production of pro-inflammatory cytokines, especially the interleukin-4 that we've seen playing a big role in atrophy. And the other thing that we usually use, there's what we call wet wrap therapy. So in this case, if someone has a very severe acute atopic dermatitis flares, and you tell them to actually dress in a like if it is a child, you apply maybe a corticosteroid ointment, and then they put on a wet cloth that has actually that ointment. So it is like the entire body is now covered, well moisturized. At the same time, the steroid is in place, so that enables the steroid to penetrate the skin well, and then also inhibit the inflammation. So other things that we can use, we have phototherapy. So phototherapy, you can use the narrowband UVB or even UVA, and sometimes people can combine it in case you have chronic cases of atopic dermatitis. Phototherapy also helps you to reduce the colonization of staph aureus and also modulates the immune response on the skin. And this is usually one of the alternatives in case you get calcitrant or very hard atopic dermatitis. So sometimes the side effects which come with phototherapy include things like sunburn, photoaging, and there's a possibility of development of cancer if you do long-term use. But most of the time we use it for short time just to get rid of the flare. When someone has cleared, then we usually switch to low-level maintenance that we are going to see. So other biologics that have been applied in treatment of atopy, you have the dupilumab, which is a monoclonal antibody targeting interleukin 4 and 13. We saw this as the major drivers of T helper 2 immune response in atopy. So this drug tries to inhibit their effect, and it is very good when you're treating atopy, and it has been used even for severe cases in adults, giving you about 50% and up to 75% improvement in the scores, in the severity scores. So you usually give it subcutaneously, where you give 600 milligrams initially, then you can give 300 milligrams twice a week. So side effects of this injection include reaction at the site of injection. Sometimes patients can get conjunctivitis as a side effect of the drug. Then we have other systemic drugs in case these other ones are not available, in case you want to try out something, maybe the others are not working well. You can use a short course of cyclosporin, which is an immune modulator. We can also use azathioprine, but in this case, you have to first test someone their functionality, because it suppresses almost every dividing cell, including the bone marrow function. So you have to make sure that someone doesn't get marrow suppression because you're giving azathioprine. And other things like methotrexate and mycophenolate mofetil can also be used for severe cases that aren't responding to treatment. And then the systemic corticosteroids are usually never recommended because of the too much side effects that are associated with them, but can be used for very acute flares. So now this is one of the most important flow chart in treatment of atopy, because if you miss this chart, just know your patient will keep coming back to you. So if you made a diagnosis of atopic dermatitis, this is the ladder that you follow to make sure that the patient actually doesn't present again with the same condition, right? So first, you have to treat the active lesions. This is red. So in this case, you give your antihistamine to for sedative, you give your antibiotics to suppress the colonization with the staph aureus, and then the very strong steroids. So you are now actively managing the lesions. So after the lesions have now gone down, you do what you call a high-level maintenance. So in that case, you focus on the hot spots where the rash loves, the flexural areas for adults, and then if it's for the child, the convex areas that where the rash love. So in that case, the rash is not there, but you continue to apply intermediate or mid-potent topical corticosteroids, maybe on 2 days in a week. Is that okay? Such that you prevent the subclinical inflammation. You also deal with the subclinical inflammation. So now after that, you do that for about a couple of weeks, 2 to 3 weeks. Then if someone has no rash now, you now go to what you call the low level maintenance. And this applies for all patients. So in this case, in low level, you are doing the routine skin care, the cotton clothing, using the gentle soap, the moisturizing, and follow up. So to make sure that someone doesn't get flares. So this is what happens usually. Our patients are a little bit funny. So after doing the active treatment, they will not even allow you to do the high level maintenance. When they see the lesions have gone, they will actually disappear, only to disturb you later on that, hey, doctor, the thing is back. So if you have to manage atopy, you have to follow this, and you have to discuss it with the patient so that they understand what they have to go through. And that's how we manage atopy. Thank you very much. I'm Dr. Abraham, and see you in the next video. Remember to share, subscribe, and comment so that you support this medical knowledge.